Ladies and gentlemen, I would now like to invite for the next presentation Dr. M.S.Yadav, that's on chronic total occlusion in STEMI, how to intervene. And Dr. Yadav is currently a senior consultant interventional cardiologist at the Max Super Specialty Hospital in Delhi. And very shortly we'll be joined by Dr. S.K. Agarwal from United Arab Emirates and Dr. P.C. Rath from Hyderabad.
Good afternoon, everybody. I would like to briefly introduce whether we should do intervention and how to and when to do intervention in a CTO encountered during an angiogram during primary PCI. So now coronary CTOs and MI, we have seen the initial data came from one of the studies, PCI in Academic Medical Center in University of Amsterdam, Netherlands. So in around 1,500 patients, around 59% had a single vessel disease. Had single vessel disease and 30% multi-vessel disease without a CTO. And 11% had a multi-vessel disease with a CTO of a non-infarct related artery. So this study showed that with multi-vessel disease without any kind of CTO, the survival was as good as the patient having MI with a single vessel disease. But those who had a CTO in the non-infarct related vessel and those who suffered a suffered an MI and underwent a primary PCI, their mortality at 1 year was around 35%. So quite significantly increased. Now, what are the potential causes which increase the mortality in the people who have a concurrent CTO and a non-infarct related artery? So there are certain theoretical explanations that there is a more pronounced negative left ventricular remodeling, and there is a higher prevalence of suboptimal marker of reperfusion after primary PCI, like absent myocardial blush rate after primary PCI or incomplete resolution of ST segment. And there was a larger infarct size as compared to the patient having no CTO, and increased risk of life-threatening arrhythmias and increased prevalence of cardiogenic shock at the time of hospital admission. So the question comes whether during primary PCI, whether we should do a culprit artery only or we should go for a multi-vessel PCI. So as we have talked that around 50% of the patients with a STEMI have multi-vessel disease. And according to the ACC-AHA guidelines, the current options are, although the gradings are different, we do just culprit artery at the time of primary. And then after the procedure, after 48 hours, whenever we are discharging, so pre-discharge, low level of exercise just to see if there is a high risk feature, which was the gold standard. And then we do a multi-vessel PCI just at the time of the PCI, primary PCI. And then another strategy is to do a primary PCI and do a stage PCI before discharge of the non-culprit arteries. So what has changed in the guidelines from 2013 so far? In 2013, it was considered to be the class 3 indication to go for a PCI for a non-infarct related artery. Means it used to cause harm. Now there are certain evidences, I'll discuss about them. Now they have changed the category from 3 to category 2B. That in few selected patients who are hemodynamically stable, either at the time of the primary PCI or at the stage procedure, you can do a PCI of a non-infarct related artery. So there has been a modification from 3 to 2B. There are 4 randomized controlled trials which were used as a evidence to change this class of recommendation. One was PRAMI, which showed that the patients who were treated with culprit artery only had around 22% events as compared to 9% those who had a treatment of a non-infarct related artery also. Another vessel was culprit only versus complete revascularization. So around 296 patients were randomized in trial, and the composite of primary outcome of death, reinfarction, heart failure, ischemia driven revascularization at 12 months occurred in around 10% patients who underwent multi-vessel PCI and around 21% patients who underwent culprit artery only PCI. So p-value was 0.009 in this case. Another trial was Dynami 3, had similar results, p-value again 0.004. Then there was a Prague 13 trial having similar results. So based on these 4 randomized controlled trials, the recommendation in 2015 changed from 3 to 2B. Now, should we treat a concurrent CTO in acute MI? So there has been a strong association between the presence of a concurrent CTO in non-infarct related STEMI patients. Raises the obvious question whether the revascularization of the CTO after primary PCI should lead to the improved outcomes or not. Theoretically, it may promote healing at the infarct border zone, improve regional wall function, result in less pronounced left ventricular negative remodeling, and potentially improve the electrical stability. So, a retrospective study done by Young et al. Of around 136 patients with a CTO in a non-infarct related artery underwent PCI, primary PCI. All of them underwent a staged procedure 7 to 10 days after the index procedure to attempt a PCI for concurrent CTO. This was successful in 64% patients. So now the data was compared in those where it was successful versus there it could not be crossed or CTO could not be done. So during 2 years follow-up, cardiac mortality was lower, around 8% versus 20.4% in the patients with a successful CTO PCI. After multivessel analysis, successful CTO PCI remained associated with reduced mortality and reduced MACE at 2 years. So now these are the trials, old trials. Now currently people are further investigating whether actually there is any benefit or because the limited data was there. So one trial is ongoing which is a explore trial, and around 4 months data of this trial has been available online right now. So Hendrick et al. Did this trial, and it was an impact of PCI for concurrent CTO in the left ventricular function in STEMI patients. So the background, as I've discussed already, that around 10% of the people with the MI have a CTO in a non-IRA, and it has increased mortality in long term. So the trial design was patients were randomized 1-to-1 for a CTO of the PCI within 7 days of the primary PCI or no CTO PCI. And then on MRI, they wanted to analyze any change in the left ventricular ejection fraction and left ventricular end diastolic volume. These were the primary parameters at 4 months they wanted to determine. So intention to treat was a difference of 4% LVEF and an LV EDP change of around 15 ml, and then expected CTO PCI success rate 80%. So around 304 patients were randomized, 150 for the CTO PCI, 154 for the non-CTO PCI, and ultimately 148 had a clinical follow-up for CTO PCI, 154 for no CTO PCI. And then ultimately 136 were analyzed for primary imaging endpoints and 144 for primary imaging endpoints in the non-CTO PCI. So these were the characteristics of the patients which were well matched, and you could see almost 40% of them had a triple vessel disease, and around 9% to 14% had a multiple CTOs. And infarct size were almost same based on the peak CPK MB value. And LVEF was in tune of around 40%. So if we could see the CTO of RCA was present in around 40% patients, circumflex around 30% versus 24%, and LAD around 24% and 25%. And then this was the TEMI grade flow in these patients. So around 40 patients had an occlusion length more than 20 millimeters. This was an important observation. So around 6% cases multi-vessel CTOs were treated, and most of the patients had a strategy of an antegrade approach in the PCI. Around 16% had a retrograde, and around crossbars or stingray technique in 3%. And self-reported PCI success rate was around 80%, and a core lab adjusted was around 72%. And around 90% of them received an everolimus lifting stent. Procedure-related complications in the donor artery was only one, this was dissection. But in the CTO vessel, 12 dissections, side branch occlusions 2, thrombus 1, tamponade 1, major arrhythmia 1, resuscitation 4, myocardial infarction 4. But there was no emergency CABG, stroke or death during these procedures. And at 4 months, if you see, there is a non-significant increase in the death in CTO PCI, 4 versus 0, but the p-value was not significant. MI also not significant, 5 versus 3. So, as such, there was no difference in the major adverse cardiac events, and the initial result of EXPLORE has been that CTO PCI within 1 week of primary PCI is feasible and relatively safe. Early CTO PCI was not associated with any higher LVEF at 4 months and not associated with any lower LVEDP at LVEDV at 4 months. In a large subgroup analysis, although, if the person had an MI due to a circumflex or RCA and his CTO non-infarct related artery was in the LAD, there was associated significantly higher LVEF at 4 months. And additional PCI of CTO located in LAD may improve LVEF, potentially improving the clinical output on follow-up. So to conclude, approximately 10 to 15% patients having STEMI undergo primary PCI or having CTO and non-RIRA. Presence of a CTO is an adverse marker, or you can say adverse association in terms of major adverse cardiac events in patients after primary PCI. A number of mechanisms may be responsible for this worsened prognosis, as we already discussed. Currently, limited data has been available on this topic. Investigations, additional revascularization of concurrent PCO is required, and the more investigation is needed to address the issue. Currently ongoing trials including EXPLORE, because it is just 4 months and they are planning it for more than 5 years follow-up. So there will be more data coming on the clinical outcomes in these patients. So that will give us more light on the topic. Thank you.
Thank you very much, Dr. Yadav. Please join the chair. We will have a brief discussion for about 10 to 15 minutes. Over to the chairmen for their comments and questions from the floor.
I just have one question to Dr. Iyengar. Do we have any data about these coronary events and then the outcomes before the STEMI network and after STEMI network? In those few centers, I'm aware that it is not, it is a short-term.
I'm not familiar with all the data, but they did present the data with streptokinase. It is in the patients who underwent primary PCI versus pharmacoengineered therapy, and it was equivalent, more or less. The results were equally good. And they also showed that once this program has started, they also had looked at the awareness, then time to door to needle time and door to balloon time, all had improved. So there's another advantage of starting this program. I don't know how any other details.
You come from Bangalore. There, I know the Uber and Ola are so popular. Do you think it had an impact?
Bangalore, we have not yet started this program. I don't know actually.
Because somebody was presenting
Somebody
the data.
presented the telemedicine, yes.
That
yes.
sometimes they are faster than
On
the
their model
ambulances.
actually.
Yeah.
On their model, they want to start similar ones.
Because in Hyderabad, the 108 MRI, the response time used to be 25 minutes 2-3 years back. Now it has gone up to something like 35 minutes or so.
Oh, I see.
Whereas my friends tell me that Ola and Uber, the response time is less than 10 minutes.
Yeah.
Professor Iyengar, I have a lot of questions for you. First of all, what is the incidence of reperfusion arrhythmias you have come across after TNK in comparison to streptokinase?
Of course, in our registry-based data, we didn't look at this. But generally, personal experience, there is no difference between the two. No difference in the, yeah.
The report on this reperfusion arrhythmias after TNK-TPA is silent actually. So far there is no data saying what is the incidence of reperfusion arrhythmia and outcome. And my second question to you, what you feel the patients, recently in European Congress the article was published saying that depression after acute MI, the outcome mortality is almost increased by 42%. So what you feel the patients group receiving lytic therapy versus the patients going for primary PCI, in follow-up period, where the patients are more prone for depression, in the lytic group or in the PCI group? This is a probable question, no data.
Yeah, I think as you rightly say, there's no data. But I think firstly it depends on the basic personality of the patient. I mean, I don't think it should make much difference if he receives any reperfusion therapy. Second problem will be the cost, the amount of money they have to spend might be a factor in producing depression. So this is all I can think of, but we don't have data. But I think it basically depends on the basic personality of the patient.
This is very important piece of information that patients with STEMI, in the post-STEMI period, those who have depression, the outcome was, this is very, very bad outcome. And the last one is what do you feel in India, the recognition of anginal symptoms, how much delay? So we have inherent delay of transport, inherent delay of going to a PCI capable hospital. The delay in the recognition of the anginal symptoms by the patient per se, what do you feel the current and the Indian scenario is how much is delayed by the time patient understands I am having angina?
Again, no definite answer, but I think there used to be considerable delay in recognition of symptoms, which I think over the period of years has improved with improved awareness and public health education.
I accept even in the Western literature, the inherent delay for the patient to recognize angina is around 2 to 3 hours. And we talk about time is myocardium, and we know that by the time patient manifests with angina, all these diastolic dysfunction, systolic dysfunction, ECG changes have happened. So as such there is a delay, and if the patient's educational status or the society, the information or the vehicles of information is less, obviously there will be a delay, further delay. So I think it's the contributory responsibility of the society and the physician. And about CTO, do you have any experience of stent thrombosis when you have done a non-IRA related PCI? And what is the vessel you had a stent thrombosis? Is it that IRA or non-IRA?
To be very honest, it was not PCI within 2 hours or 3 hours of MI, but it was kind of a partially flowing vessel we were doing it. And then I don't know, because it was some issue with the shelf life of heparin or something, we were doing that PCI on the heparin, or maybe it was related to the loading of the antiplatelet therapy. So that in that case, we had a PCI of this thing, culprit vessel done in that case. And then we saw the patient was hemodynamically stable. It's already been a day after PCI, after the MI and receiving a thrombolysis. So then we did a PCI of a CTO at the other vessel. And then we faced the similar problem. Either maybe it was related to the prolonged procedure or something. And then although as a record, as a routine, every 15 to 20 minutes we check the ACT frequently. So there were very erratic readings, right from going up to 500, then suddenly coming below 200. So there was a lot of swing. I don't know whether there was any heparin resistance or there was any clopidogrel resistance in that case. And then we had to encounter a thrombosis 1 hour after the PCI in both the vessels. And then we had to re-explore the patient. We had to reload with the prasugrel, to be very honest. And then we had to use on top of prasugrel a half dose of 1 bolus of 2B3 in that case. And finally, we could achieve a good result, and there was not much deterioration of ejection fraction. And fortunately, that patient did not land into a cardiogenic shock or a heart failure or something like that. And we could discharge within 3 days of time frame to the patient.
Yeah, you mentioned about one study where they did the CTO after a week. within a week they did. No, do you think it is better to do a viability study in that particular area than do the intervention?
To be very honest, that's why I was saying that this data had been in the patients who had a relatively well-preserved EF, if you see, 40% plus. So assumingly they could be having. But to be very honest, as a dictum for opening up a CTO, there are two things required. You should have a viable myocardium and reversible ischemia in that territory. Or you may not have a reversible ischemia on a routine investigation because of 100% occlusion. So at least a viability study should be done before attempting those. So that can be done in between the time frame. That should be incorporated. So I think it's a new era and it needs to be further evolved. We shouldn't blindly attempt every CTO in those all cases. To be very honest, if you ask me if LAD territory is viable and CTO is in LAD territory, which is a non-infarct related territory, I would say there will be maximum benefit to open up that CTO after a PCI, primary PCI further vessel.
After this PREG 18 data, will you like to start a PCI of a non-IRA straightforward with the prasugrel instead of loading with the clopidogrel? The PREG 18 data came.
As a character of CTO PCI, we know that they are known to have, at least before the drug-eluting stent, they were known to have more restenosis as compared to the native lesions, which were non-CTO. But now with the CTO also, we have seen that they have a little statistically significant more restenosis in those. So I don't know whether an antiplatelet will help in restenosis, but at least in thrombus formation, particularly when you have not done a proper imaging during the PCI, and you think there could be a little error during the procedure, like malapposition, non-apposition, or while opening up a stent in the CTO, doing a little harm to the stent. So I would like to go for an antiplatelet therapy, which is much more reliable than the clopidogrel alone.
Okay. There are any further questions, Mr. Chairman? There are none? Call the...
From the floor, any question?
So my question is not addressed to anyone of you in general, but it is a very concerned question, because whenever we treat MI, it is we are making such a clear-cut linear distinction between STMI versus non-STMI on the basis of simple ECG ST elevation and non-ST elevation. I feel surprised because we have been seeing that sensitivity of the ECG for diagnosis of even ischemic heart disease, angina, is reasonably poor. But in MI, how we are so sure? Because ultimate distinction lies inside the thrombus, whether it is a white thrombus or it is a pink thrombus. And that decides whether we are going to lyse this thrombus or we are going to give it thrombolytic therapy or anticoagulant therapy. So how the ECG can become so precise in distinction that this is, because in my practice, I am professor of medicine for the last 10 years, I have found every day when I feel concerned whether I should thrombolyze this patient or I should put this patient on, because there is, for example, I will give you one example. A patient comes who is already having ST depression because he is a stable angina patient. He comes with pain in chest. His top is positive. Now, whether he has developed ST, non-STMI or not, I am not sure. Within few hours, I find his ST is fiery. And he has developed a STMI. And I have already given him anticoagulant and loaded with aspirin. So don't you think that all of us face this kind of problem every day, or you feel comfortable that there is a very distinct, clear-cut, shining line between STMI and non-STMI? Because I feel surprised that every time we keep on discussing STMI, non-STMI, we don't find any gray zone area where either of these two, they are converting into one another, because this is an ongoing continuous process of thrombolysis, thrombus development, and converting into a red thrombus. And because treatment is diagonally opposite, in one we are thrombolizing another, so every day, as far as I am concerned, once in a month I feel concerned that I am treating right or I am treating wrong. So I will like to have opinion of this very senior faculty members in this area of this gray zone area of ST versus non-ST. Okay, enzyme is elevated, that is true, pain has come, that is true, but ECG is showing elevation or non-elevation. Sometimes even there is no change in ECG. And patient comes with acute pain, you find his dropped eye is positive, and there is hardly any ECG, appreciable ECG change. Now where to put him, whether we thrombolize or not thrombolize, and what to do?
I think
in the evolution of the terminology of the infarct. 20 years back, we used to call them as transmural infarct and subendocardial infarct. But then, when the autopsy studies came, based on the ECG, when we made a diagnosis of transmural infarct, it was not always transmural. Based on the ECG, when we made a diagnosis of subendocardial infarct, it was not always subendocardial, it could have been transmural as well. So the terminology changed at that point in time from a transmural subendocardial to ST elevation and non-ST elevation MI. All the data that has accumulated over a period of time on the value of primary PCI or thrombolytics is applied to that classification, ST elevation MI and non-ST elevation MI. The thrombolytics were found to be not useful in non-ST elevation, could be harmful, but they were found to be useful and very useful. Statistics were good when it was a ST elevation MI. So we continue to use that criteria. That is one reason. The other reason is you can make instantaneous decisions by looking at the ECG. So you are not going to require much more information and spend a lot more time to find out. A simple 12-lead ECG is good enough to tell you whether it is a ST elevation MI or non-ST elevation MI. So which makes the algorithm so much simpler and adaptable and scalable. That was the main reason why it went on that way.
I just wanted to have an extension of this. First of all, what is your aim of treating an ST elevation MI? And what is your aim of treating a non-ST elevation MI? So in the ST elevation MI, we are sure. In the non-ST elevation MI, there are two components. One is what is there in the ST elevation MI, and second, preventing for the patient to going to ST elevation MI, which is not there in STEMI. In the STEMI, when you are treating, you are trying to protect the myocardium. In the STEMI, when you are treating, you have two aims. You are protecting the myocardium, and you are not allowing the patient to go into STEMI. So that is the quite natural when you are treating a patient of STEMI. During the course of hospitalization and treatment, the patient can progress to STEMI. I think that answers your question.
There's something more, you had a second part of the question.
My concern is not regarding diagnosis and treatment. My concern is the sensitivity of ECG is so much that it can decide with a clear signing line between STMI versus non-STMI.
Yes.
That is my concern.
As on today,
because
the distinction is one. As on today, the distinction is very clear. Okay. Chest pain, ST elevation, the ischemic pain, it is very clearly ST elevation MI. You have to differentiate it from chest pain and non-ST elevation acute coronary syndrome. The distinction is very clear based on ST elevation and the enzyme changes, because the treatment is entirely different.
I fully agree with you, sir.
But you cannot give...
My point of concern is not this at all. My point of concern is this visualizing ST segment versus non-ST segment, the type of thrombus which is sitting inside.
Yes, as on today.
Should we have some other test which is going to tell you whether this is a platelet-rich thrombus or a thrombin-rich thrombus which is going to make a difference between the line of management.
As on today, because that is the distinction for ST elevation MI.
With Philip flops.
Yeah, Dr. Ramakrishna.
I think I want to add a comment. It came in the reverse way. The thrombolytic trials initially included all patients, and they shown that clearly patients who don't have an ST elevation did not benefit, and in fact it was harmful. So that is why this distinction initially came. Once the primary PCI kind of a thing came up, only the patients with ST elevation MI were undergoing primary PCI. Then people wanted to actually take this concept in unstable angina or NSTMI, that once the patient comes, immediately they should be revascularized. Yes. And then they realized that possibly doing it is again harmful. Yes. So that is why the same scenario has sticked in. Rather than using ECG, it actually came the reverse way, based on testing of the therapies, and that is why this is still holding true.
And for his question, what he asked about the ECG, I'll just remind you here, only single ECG will pick up the ACS patients only up to the tune of 80%, not 100%. That is why there is a clear-cut recommendation when to repeat an ECG, second ECG. It is any alteration in the clinical condition of the patient or routinely 4 to 6 hours intervals. It is why to pick up the hidden things at most 20%, which is not 5% or 2%. So it is not a forced ECG who should stay clearly STMI or NSTMI. The ECG has to be repeated at frequent intervals depending upon the clinical condition of the patient.
There is another category of MI which thankfully to you did not bring out into your question. There is an MI called as non-ST elevation, non-ST depression MI. Right? ECG is normal, looks normal, but there is an MI. This can be picked up by your biomarkers like high sensitivity trop within 1 hour these days, within 1 hour to 2 hours, not like 8 hours to 12 hours before. Then the second thing is you can also make it out on MRI, gadolinium MRI. You can make out the micro-infarcts in the myocardium on gadolinium MRI. If you have the facility, and you can do that, you can diagnose micro-infarcts. When you find a patient, ECG is normal, there is some symptom, trop is high, you don't know why it is high, there is no other reason. Some of them, at least majority of them, are micro-infarcts or small infarcts which are not shown up on the ECG. All said and done, ECG is a very crude test. It is a very crude test, but very useful, very cost effective, and can be done anywhere and probably everywhere. Okay. That is the reason why they try to make it simple.
Thank you very much.
I would like to put a scenario of a case of a acute MI with classical symptoms and classical signs of ST elevation on ECG, and patient is at a remote place where a facility of only a physician at a PSC or we may say community health center is available. So is the physician right in giving tenecteplase at least, because it doesn't require any IV infusion and all, without confirming that acute MI ST elevation by trop T or trop I, sir? Is he justified, sir? At least the patient can be thrombolized and subsequently he can go for a pharmacoinvasive therapy to salvage the myocardium.
That's perfectly acceptable. I think Dr. Iyengar is in a better position to answer that.
Sir.
Yeah. As you said, patient has come with typical ischemic cardiac pain.
Yeah, patient with classical symptoms and ST elevation MI.
We can go ahead with
tenecteplase, even if we have not done the trop T or
apart
trop
from
I.
the initial reassurance, antiplatelets, pain relievers.
Yes, sir.
Promote.
Thank you.
Okay, that's all we have time. Thank you very much, chairpersons. It was a very enlightening session. We'd like to thank our speakers.